It's my pleasure now to introduce tonight's speaker, Dr. Paul Chang. Dr. Chang is a board-certified periodontist and prosthodontist practicing in McKinney, Texas. Dr. Chang attended the Baltimore College of Dentistry in Maryland, where he earned his doctorate of dental surgery in 2003. He then completed an extensive 5-year residency program at the University of Texas Health Science Center at San Antonio, where he was awarded specialty certificates in both periodontics and prosthodontics. While in San Antonio, he also completed his research on biomodification of titanium surfaces to improve implant stability and earned his master's degree in the School of Biological Science. Less than a year after completing his residency, he successfully challenged both the American Board of Periodontology and the American Board of Prosthodontics board examinations. Dr. Chang is one of 5 dual board-certified dental specialists in both perio and pros in all of the United States. Terrific, Dr. Chang. And we're so happy to have him with us tonight. He's an adjunct professor in the Department of Prosthodontics at the University of Texas Health Science Center and actively involved in numerous dental societies and dental associations in Texas and nationally as well. With that being said, it's my pleasure to warmly welcome tonight's presenter, Dr. Paul Chang. Dr. Chang, take it away.
All right, good evening, everyone. Thank you, David, for the introduction. Today, I would like to talk about a very hot topic in dentistry today. That is the management of peri-implant disease. Since Professor Bernard placed the first implant in an edentulous mandible some 50 years ago, dental implant has revolutionized modern dentistry. Dental implant provides superior aesthetic results and chewing function compared to traditional prosthesis. Not to mention, study after study have found that overall success rate is 95% or higher. Before we talk about implant disease, we need to know what a healthy implant looks like. Clinically, a healthy implant does not have gingival inflammation, no BOP, no suppuration. In general, probing depth should be less than 6 millimeters. This is not to say that you should be probing every time you see the patient for a SPT. There also should be presence of adequate keratinized mucosa to help protect underlying attachment apparatus. Radiographically, with the platform switched internal connection implants, we should expect to see crestal bone at or coronal to the implant platform. Many published, well-controlled retrospective studies have shown that most implants are still in function 10, even 20 years after placement. Based on these exciting findings, we're used to see these kind of statements on dental office advertisements regarding dental implants. Lifetime warranty, lifetime solution. How many of you are still promising that to your patient when they come in for an implant consult? I don't think there's many of you guys who are doing that. If dental implant have been so predictable and long lasting, then why in the last 5 to 7 years, my private practice, as well as many of yours, have been managing more and more patients with implant complications? Dental implant is a multi-billion-dollar business. In 2019, world dental implant market is estimated to be valued at $4.6 billion. According to iData Research, in 2020, there were 3.4 million dental implants placed in the United States alone. If you look at the pie chart on the right, United States market is only about 30% of the global implant market. It's being estimated that over half of the dental implants are being placed in general dentist's office nowadays, rather than in a specialist office. Is there a difference in success rate between the real world dental practices versus what's being published in the journals? Yes, there is. The Salvia looked at the implant survival rate in a group of 87 practices in 25 states. He found that 81% implant survival rate at 5 years. That's almost 15% lower compared to the 95.8 survival rate published in the journals. One reason might be that the published study result is based on a patient group that's been handpicked to eliminate other risk factors, such as what? Diabetes, osteoporosis, periodontitis, smoking, etc. And also implants were placed and restored by very experienced clinician in those studies. Dentists are placing an increasing number of implants into far less ideal sites nowadays as well. Surgical protocols today includes implants placed at the same visit as tooth extraction, immediate provisionalization, and in some cases, immediate occlusal load as well. They all increase the risk of peri-implant complications. In real world, our dental office often face patients with systemic issues as well that can affect implant success rate, such as what? Diabetes, osteoporosis, smoking, and periodontal disease. Implant complication can be divided into two categories. The early complication, which is failure before osseointegration, which I don't have time to go into it today. Instead, I will focus on late complications, which is after implant has been osseointegrated. The number one cause of implant complication is insufficient emphasis on implant maintenance. We know buildup of biofilm and calculus around implant prosthesis will initiate peri-implant mucositis, and if not controlled, will often lead to peri-implantitis. Did you teach your patient how to clean around an implant last time you fabricated an implant restoration? Is there a special technique or flossing technique they need to use? Does your hygienist know how to perform supportive periodontal therapy around an implant? Or did they just skip it around since they were taught not to use the curette or Cavitron around an implant? These are some of the things to consider. With increased time in function, prosthetic complications such as screw loosening will increase significantly. Does any of you proactively check the torque value of your custom abutment on a single implant crown or a bridge? What about a multi-unit on a hybrid? Why do you think this patient is having severe bone loss around the implants? Can you see the gap between the implant and the hybrid prosthesis? Another case. Again, the gap between the implant and prosthesis is telling me most likely the entire bridge has been loose, which is probably the main reason for bone loss around these implants. This brings me to the Albertson's article in 2016, which he questioned if peri-implantitis is peri-implantitis is truly a disease, or is it just the bone loss resulting from many different complications caused by implant treatment itself, such as certain implant types, clinician error, patient conditions, treatment protocol, and quality of treatment. So let's look at the definition of peri-implantitis. According to the latest World Workshop, it is defined as pathological condition occurring in tissue around dental implants, characterized by inflammation in the peri-implant mucosa and progressive loss of supporting bone. They also listed 10 risk or contributing factors for developing periodontal disease. First is history of periodontitis. Implants placed in patients with history of periodontal disease has significantly higher odds for developing peri-implantitis, such as this case. Just like we talked about earlier in the presentation, patients with poor plaque control skills and no regular supportive periodontal therapy have higher risk of developing peri-implantitis. Smoking has been strongly associated with chronic periodontitis, attachment loss, as well as tooth loss. With current available data, we know a patient who smokes more than half a pack a day have a higher chance of developing periodontitis as well as peri-implantitis. It is important to know the prevalence of diabetes is increasing in many countries. It is currently estimated that 415 million adult world population have diabetes. According to CDC, it projected that by 2050, 1/3 of the adult in US will have diabetes. Many studies have shown that patients with hyperglycemia are 3.3 times likely to develop peri-implantitis. Evidence has suggested that less than 2 millimeters of keratinized mucosa is associated with more plaque accumulation and peri-implant soft tissue inflammation. Patient has also reported that they have more gum sensitivity when there's less keratinized tissue around the implant, thus preventing them from performing proper oral hygiene around an implant. Presence of cement is closely linked to either peri-implant mucositis or peri-implantitis. However, the portion of disease implant sites varies considerably, probably due to present or absence of other risk factors, systemic and local factors. For a while, many speakers were advocating what? Placing smaller implants to ensure there's sufficient bone surrounding the implant and to achieve better result. But when you have poor crown to root ratio, like this case, implant complication is bound to develop. Here, the abutment has been fractured at the implant platform. The only thing that's holding the crown is the loose screw. And we know that can often cause what? Bone loss around the implant. Iatrogenic factor is a big lump of factors that don't fit anywhere else. Like I mentioned earlier, surgical errors, poorly designed restorations can all contribute to peri-implantitis. Titanium corrosion and titanium particles can cause a foreign body reaction and result in inflammatory response in both soft tissue and surrounding bone, which will result in bone loss and recession. This is a very important risk factor and then being looked at very closely. I want you to take a note of this factor, as this is one of the main reasons why I elected to incorporate a Erbium laser in my periodontal practice. Dr. Wilson's human biopsy study reported that 94% of human peri-implantitis cases contained titanium particles and dental cement. He noted that these materials were surrounded by inflammatory cells, which causes bone resorption. So how does World Workshop definition and risk factors of peri-implantitis compare to Dr. Albertson's risk factor for implant complications? Very similar, doesn't it? So again, is peri-implantitis a disease or complications resulting from functional loading? Let's look at the clinical presentation of peri-implant disease. According to the latest AAP World Workshop, clinical presentation of peri-implant mucositis should show gingival inflammation, BOP, suppuration with probing depths of less than 6 millimeters. The most important thing, without loss of supporting alveolar bone. Peri-implantitis should include all the clinical presentation of peri-implant mucositis, but also include progressive loss of supporting bone based on serial radiographs. So how often do peri-implantitis occur? Based on Dirk's systemic review, it's been estimated to be around 7 to 12% of implant at 5 years. And it can increase to as high as 45% of implant when we get close to 10-year period. 45% of all implants. Does this number sound familiar to anyone? Remember the National Health Nutrition Survey done in 2009? It has found that 47% of US population have periodontal disease. So we not only have an increased need to manage periodontitis, but we also have an increased need to manage peri-implantitis nowadays. So people all ask, why spend so much money to buy a laser? What is my ROI? Well, here it is. According to the iData research, approximately 13 million implants have been placed from 2017 to 2021. We know 7 to 12% implant will develop peri-implantitis in 5 years. So let's do the math. There are currently 1 million to 1.5 million implants that have peri-implantitis and needs to be managed. Patients who spent tens of thousands of dollars to have implants placed and restored, most of them are willing to spend the money to save their implants. There's your ROI. So my point so far is that it is way easier to prevent peri-implant disease from occurring in the first place than trying to manage it once it has occurred. Because as you all know, it is not very predictable due to all the risk factors that's involved. Before implant placement, we need to make sure we stabilize systemic risk factors. We need to treat periodontal disease. Don't just jump into the implant. During implant placement, make sure the site has been idealized, soft tissue and hard tissue. If not, augment them first. Make sure implants are placed with final restoration in mind. Not too deep, not too shallow, not too big, not too small, just right. During restorative phase, we need to ensure abutment fully supports the soft tissue. Avoid excess cement. Evaluate occlusal overload. And ensure the restoration is retrievable if at all possible. Lastly, we need to make sure patients are taught proper home care around the implant and follows a strict supportive therapy. If we follow all of that, hopefully we can decrease the percentage of peri-implantitis in our practices. So now, finally, let's get to the actual management of peri-implantitis. Notice I said management, not treat. I learned that from Dr. Sam Lau. Patients need to have a realistic expectation when it comes to peri-implantitis treatment. We cannot cure peri-implantitis. In 2012, Dr. Form and Rosen published a paper. They classified peri-implantitis based on the amount of bone loss. It is very simple, very easy to follow. They classified early stage is when bone loss is less than 25%. Moderate stage is 25 to 50% bone loss. An advanced stage has greater than 50% of bone loss. Same as treating periodontal disease. The more bone loss an implant has experienced, the less predictable the therapy becomes. Sinjab published an article on what kind of therapy is recommended based on the amount of bone loss. When you have an early stage peri-implantitis, you can potentially treat with non-surgical therapy first. If it is not effective, then move to surgery. Moderate stage treatment is based on the type of defect. It can be a regenerative approach, it can be a resective approach, or it can be a combination of both. Now, when you have over 50% bone loss, it is highly recommended that you remove and replace. So, can we re-osseointegrate a contaminated implant? right? If we're trying to regenerate, we need to know if that's possible or not on a contaminated implant. Well, based on systemic review by Rembert, it is possible as long as the surface, implant surface, has been decontaminated thoroughly. What about the question of, does treating implant surface with an erbium laser affect the re-osseointegration process? The answer based on Yamamoto's study is no. He took commercial implant, he treated half of the implant surface with erbium laser and left the other side alone before implanting into beagle dogs. And then he performed histological exam. What it showed, as you can see on the bottom right, bone formation on both sides of the implant. So once we have decided surgical therapy is necessary, I like to follow the Foreman Rosen's 8-step regenerative approach in treating peri-implantitis. First and foremost, we need to make sure, again, patient is compliant. Second, we need to make sure the implant is mobile, okay? They recommend flap access to ensure visualization of the implant surface so decontamination can be performed properly, because that is the key. Again, out of the 8 steps, step 3 and step 4 are the most important steps, because if implant surface is not thoroughly decontaminated and the granulation tissue containing bacteria, titanium, and cement particles not completely removed, then regenerative therapy around an implant will not work well. I am not going to go into detail with the rest of the steps due to the time constraint. But if you have been performing periodontal regenerative therapy on a natural dentition, the guideline is pretty much the same. So let's focus on biofilm decontamination. A variety of methods has been described and recommended. Most of studies have shown that they all work equally effective in decontaminating the implant surface, or ineffectively, depends on which article you read. They perform similarly. However, what happens to the titanium surface if you choose to use chemicals such as hydrofluoric acid, citric acid, hydrogen peroxide? Corrosion maybe. What about release of titanium oxide particles? What about if you decide to perform mechanical decontamination, such as using a titanium brush, a burr, or piezo scaler? Well, what about the release of titanium oxide particles into adjacent bone and soft tissue? Remember, the release of titanium particles has been listed by World Workshop as a risk factor for developing peri-implantitis. So the key here is we want to decontaminate the implant surface thoroughly, but at the same time, we don't want to change the surface characteristics. So re-osseointegration or regeneration can occur. What is left on this chart? Well, there are only 2 methods left. One is air powder device using glycine or erythritol powder. The other is the use of laser therapy. I have both in my office. So now let's talk about lasers. Lasers can be intimidating because there are so many different types of lasers based on the wavelength. Many of my colleagues often tell me, laser's a laser. I'm just going to get one for marketing purposes so that I can tell my patients, yes, I have a laser in my office. Well, that doesn't really help you with your ROI, does it? In general, laser in dentistry works in either targeting the pigments and hemoglobin, or water and hydroxyapatite. Lasers such as diode and the ND laser are effective on pigmented cells and hemoglobin. Laser such as erbium laser has a high affinity to water and hydroxyapatite, which is present in both hard and soft tissue. There are 3 laser systems that are beneficial to perio procedures. They are diode, ND laser, and erbium. Diode and ND are soft tissue only lasers. They work well in killing periodontal pathogens, which are pigmented anaerobics hiding in the periodontal pocket. Diode and ND laser targets the pigmented tissue, which allows the effective debridement and disinfection of the pockets, as you can see here. Now, what about the erbium? Erbium laser targets water and hydroxyapatite, as I've told you. It kills the bacteria by heating the water molecules inside of the bacterial cell, causes the water molecule to explode, right? It cuts the hard tissue by rapid thermal expansion of water molecules within the enamel and bone. This causes what they call a thermal mechanical acoustic shock wave that pulverizes the enamel and bony matrix. Because erbium laser also uses air and water, as you can see here, when we make a soft tissue incision, there's very, very minimal collateral thermal damage done to the soft tissue compared to the diode and compared to a ND laser. Both diode and ND laser are not well absorbed by water or hydroxyapatite. So when they're used on hard tissue, such as root and bone, laser energy is transformed into energy, which increases the surface temperature and causes thermal damage. As you can see on these videos, you see the carbonization of the bone versus when you have a erbium laser, it has a shallower penetration. So it has the ability to remove calculus and the superficial layer of infected cementum without significantly increase the pulpal temperature. Okay, it is also capable of removing smear layer without causing carbonization and formation of craters like these soft tissues. As you can see, the bleeding line right here is actually made with the erbium laser. And then you can see these charred incision lines on the bone is made using the diode and the ND laser. So not all lasers should be used to decontaminate the implant surface. I have to be very, very specific. You know, a lot of people ask, well, can I use this laser? Can I use that laser? Well, it has to be very specific, okay? It's been shown that due to high peak power, when you use an ND YAG laser, when you point the ND YAG laser directly to an implant surface, there's high risk of partial melting or cracking and formation of craters on the implant surface. It doesn't matter what power output you use. And this is very critical. We don't want to change the implant surfaces, right? And we don't want to increase the surface temperature of the implant, which can cause it to lose osseointegration instead. So erbium laser works differently from the ND and the diode laser. Think of erbium laser as your electrosurge, piezo, and high-speed handpiece combined. Erbium chromium YSGG laser, when used with constant water irrigation and appropriate power setting, causes no visible changes on titanium surface with minimal temperature elevation, as you can see here. I'm using the laser to decontaminate the implant surface, and then at the same time removing the granulation tissue. Just as I said, you have the water, you have air, and you have the power of the laser. There's no better tool to clean around a implant surface than the erbium laser. So as my buddy Scott Dow often says, do you have a study to back it up? That erbium laser does not change the surface texture of an implant? Well, as a matter of fact, I do. So let's look at this SEM study. In this study, Adele et al. Took 50 Zimmer microtextured titanium implants. They soaked 25 of them in Actinobacter solution. And the other 25 of them, they soaked in the Pseudomonas containing solution. They soaked it in there for 48 hours. After 48 hours, they were then washed with saline to remove unattached bacteria. Here's how they look under the SEM after bacterial inoculation. Image C is an example of titanium implant bathed in the Pseudomonas solution at 12,000 magnification. You can clearly see the rod-shaped bacterial colonies on the implant surface. In the image D is an example of implant bathed in the Actinobacter bacteria colonies. And again, there are abundant amount of rod-shaped colonies on the surface. So, and then what they did is they divided the samples into 4 treatment groups. Group 1 was treated with BioLase erbium chromium YSGG. Group 2 was treated with 650 nanometer diode after the surface has been painted with toluene blue. This is a technique they also called laser photodynamic therapy, okay? Group 3 is treated with a 808 nanometer diode laser. Group 4 was treated with chlorhexidine solution. And after treatment, the implants were evaluated under SEM, and a bacterial culture test was performed as well. So guess what they found? So here is the SEM. The image A is the erbium chromium YSGG treatment group. Image B is the laser with toluene blue. Image C is the diode. Image D is the chlorhexidine. You can see the only surface that appears to be clean and unaltered is what? Is group 1, erbium chromium YSGG laser. All other methods still showed dense bacterial colonies remaining on the implant surfaces. They also performed a culture study after treating the implants. As you can see here, group 1 erbium chromium YSGG laser had the lowest viable bacteria count compared to all remaining other test groups. The second best was the chlorhexidine group. Okay. So conclusion, erbium chromium YSGG is very effective in decontaminating implant surface without changing its surface characteristics. And guess what? That's what we need to be able to re-osseointegrate an implant, correct? So as you can see, the SEM image on the left is a sterile implant that's not being contaminated and not being treated. Versus on the image on the right is implant being contaminated with the bacteria and then treated with erbium chromium YSGG. Not too much of a difference, right? Very powerful study, very good quality image. So what is the BioLase implant repair protocol? How do you learn about it? Well, BioLase does not keep their protocol behind a vault. You don't have to sign up for a year-long boot camp and sign a non-disclosure agreement to learn about it. It is right on their website, www.biolase.com, okay? Due to the time constraint, I'm not gonna be able to go through every single step. So instead, I will focus on the implant decontamination step, okay? Seeing is believing, right? So let's take a look at this video I made specifically for you guys, just to show how effective a erbium chromium YSGG is on removing biofilm, calculus, and diseased bone on an implant surface. So this is the implant I took out. And I placed it in sterile water, and then now I'm using the erbium chromium YSGG laser to performing decontamination as I would in a patient's mouth. Look at the particles being washed out from the implant surface. Look at that. Look at all the contaminants being washed out. Remember, the laser kills the bacteria by direct energy, and also the erbium laser, when it interacts with water, it causes micro explosion, right? Imagine you're using a power deck washer on the implant surface. Look at that. Is there any other method that can do the same on an implant without changing its surface texture? I don't think so. Look at the area. Look at the area after I did the laser. Look at the area. It looks like a pretty clean implant surface to me. Pretty powerful. So some of you might say, hey, doc, it looks good, but you were angling the tip towards the implant surface because you got to be able to directly shine the light onto the implant surface to make it effective. So what happens when you have a deep walled defect like this? How do you clean the bottom of this defect? Well, here's my answer. BioLase is the only company, to my knowledge, that makes this kind of tip. It's called a side firing tip. Okay, so basically it bends the light at 90 degrees. So you're able to reach all the way down to the deep intrabony defects and clean the implant surface properly. You can clean the pitch, the groove, the threads. You are able to do as good a job as you can without taking the implant out. Again, look at the contaminants being washed or being exploded out of the implant surface. Again, no other techniques can clean between the grooves. And now we know most of the bacteria remnants are found hiding in the grooves. So with this side firing tip, you can perform implant repair procedure either via a close approach when you have a shallow defect, or maybe you think there's some excess cement that you need to be removed. Guess what? You can perform it with the side firing tip without reflecting a flap. And look at here, that you see the little white tip right here? It tells me where the light is being shined to. It's opposite of that white indicator. And you notice I can turn the tip into many different directions so I can clean the implant surface 360 degrees. Notice the tip is being turned to different angles so I can get into the different sides of the implant surfaces. Again, here is the open approach. Again, decontamination of the implant surface, removal of the granulation tissue is critical to ensure regeneration success. Look how clean the surface is. I'm able to get into all the nooks and crannies to remove. Look at that granulation tissue. I'm removing that granulation tissue just with this one instrument alone. So with that said, I will end the lecture with a case, just kind of show you the overall steps. So here in this case, I have a patient who had the implant placed about, as she reported, around 7 years ago. And she came in, she said, I noticed that my gum is receding and is tender to the touch. Okay, so as you can see here, the implant number 9 does not have the keratinized tissue and is slightly inflamed. And here's the peri-apical radiographs. We can see there are some bone loss at the implant platform level. So here I took off the implant crown and reflected the flap. As you can see, there are a lot of granulation tissue surrounding the implant surface. Here, I'm using the laser to degranulate the granulation tissue surrounding the implant. Here, I'm using the sapphire tip to decontaminate the implant surface. Here, I don't know if you can see it clearly, I use the laser to decorticate the surrounding alveolar bone. Remember, we decorticate the bone when we try to perform a lateral ridge jog, right? When we try to do regenerative procedures, we want to decorticate to induce blood flow and recruit growth factors. Here, I'm using biologics. Here, Emdigain is being applied. A FDBA with a membrane. And also, guess what? Because we need keratinized mucosa, a soft tissue graft. Oh, here's the BioGuide in place. And here is soft tissue graft performed to increase the amount of keratinized tissue surrounding the implant. Immediate. So here on the left, you can see as a 1-year follow-up, we have covered the exposed custom abutment. We have changed the tissue type into a healthier, more resistant keratinized tissue. Here you can see on the left is the 1-year follow-up, and then on the right is the pre-op. So in conclusion, the etiology of peri-implantitis is thought to be a multifactorial, including lesions from implant attachment, excessive mechanical stress, and corrosion, all in the presence of pathogenic bacteria. As with periodontitis, clinician must consider a host of resistant factor. Nevertheless, untreated progression of bone loss in the presence of peri-implant mucosal inflammation appears to be the primary etiology of the implant failure. So I really just want to re-emphasize that prevention is the key. We want stabilize the systemic factors, treat the periodontal disease. We want to perform ideal surgeries. We want to pay attention to when we restore the implant. Then we can ensure less of chance of developing peri-implantitis. Okay, when we treat peri-implantitis, case selection is critical. Remember, we need to evaluate and address all risk factors before surgical therapy. So with that said, as we begin to understand the characteristics of laser more, the role of laser in periodontal and peri-implant surgeries will expand rapidly. I'm very, very excited to be part of it. So with that said, this is the end of my presentation. And David.
Thank you very much. Yes, thank you very much, Dr. Chang. I appreciate that. I never fail to learn something, or usually more than one thing when you speak. So thank you for sharing your clinical experience and experience in different modalities with us. Very much appreciated. As I suggested, we have some time for Q&A, Dr. Chang, and we do have some questions that I've been able to catalog. I would say to anyone in the audience, there is still time. I think we would be able to fit in another question or two. So if you have one in mind, please type it into the Q&A panel there at the bottom. And as I promised early on, I'll get it in front of Dr. Chang. So Dr. Chang, without waiting any further, let's get to some of those. Let's see, they were curious, Dr. Chang, about tips and settings. I thought you did a nice job of talking about laser energy and where it comes out from and how you're directing that the implant service. But can you walk through perhaps your personal protocol with tips and settings and give the audience an idea how you're getting after that piece of it?
Yes, yes. So again, this is part of the reason, I believe at least, why laser is not being widely adopted, because there's so many different settings. There's the hertz, there's the power, there's the air, there's the water, there's the what tips do you use? There's a psi firing tip, there's the radar firing tip, there's end firing tip. Now, the good thing about BioLase is they have everything already pre-programmed into the machine. You don't have to remember the specific settings nor the tips, because when you go into this touch screen, it's like a touchpad. It's like an iPad. You go in, you click on implant repair. It will walk you through step 1 to step 5. It will automatically pre-program all the settings: the power, the hertz, the water to air ratio, and then it even tells you what tips to use for every single step. So that makes it a lot easier to get familiar, get used to using a laser. And once you get familiar with it, then you can slowly tweak the power setting based on your preference. So right now, I mean, that's how I recommend.
Excellent. Thank you, Dr. Chang. This is an anonymous attendee. I typically, indicate where the question is coming from, but how do you decide when to do closed versus open flap debridement?
So I think it depends on, number one, depends on your comfort level. Being a periodontist, I would always prefer to open. Again, just like Dr. Forum, Dr. Rosen, they all perform flap. Why? Because we want to eliminate biofilm. We want to sterilize, decontaminate the implant surface as much as we can. We know we cannot eliminate 100%, but we want to eliminate as much as we can. We want to remove all the granulation tissue. If you do a closed approach, like some of the other techniques, how do you remove the granulation tissue? How do you ensure that you have totally decontaminated the implant surface? You don't know. You don't know if you don't see it. So in my office, I am 95 or more % in open and flap.
Thank you for that. And there's a follow-up question from the same individual about your decision tree or decision process for when to graft or not after debridement.
So I didn't have time to go into it too much today, but basically it's based on the defect type. Is it a intrabony defect? Is it a supracrestal defect? Is it a contained defect? So based on the defect type, then you decide whether you graft or not. But in general, if it's a contained defect, meaning the implant, anything is like a crater type of defect, then I would graft. Anything above the bone, then you really can't. The chance of rebuilding the bone vertically is very, very difficult. So another analogy is I tell patients, I can fill a pothole pretty predictably. But if you want me to stack cement on top of the cement, that's going to be a little bit difficult.
Sure. No, that's a good way to look at it, doctor. This was from Joel Paga, and it's more about the incidence of peri-implant disease. And the question is, do you, Dr. Chang, recommend screw retained restorations rather than cementable so that some of these peri-implant conditions can be avoided?
Yes. So it is very it's a very difficult question to answer. Number one, I will always, I think I didn't mention it clearly, but in my earlier presentation, I will always recommend to make a restoration that's retrievable, because we know their implant restoration are bound to have some sort of complications down the road. It may be 5 years down the road, it may be 20 years down the road, but we want to be able to retrieve it. So I always prefer a screw retained restoration. But on the other hand, I want my implant to be totally embedded in the bone. So if it's an anterior implant, and guess what? I will place the implant where the bony housing is. I'm not going to place it outside of the bony housing just so I can get a screw retained restoration. So most of my anterior restoration, guess what, is cement retained. But there are ways that you can cement this crown onto the implant abutment without getting the excess cement subgingivally. There are different techniques, which I didn't have time to address, but there are a lot of different techniques that you can do to minimize the cement from going apically.
Sure. And with this level of interest, doctor, I think we can easily foresee you coming back and doing a deeper dive into, more of that information and some more technique there. But I certainly appreciate as much as you covered in the time that you had.
Right.
I think some of the questions are really asking you to tell more about that. So in the guise of an hour, it's pretty tough to do some deep dives there, but I thought you did a nice job covering some of that.
Yeah. David, one more thing.
Yes.
One more thing,
Sure.
David. So this is more for you. So I heard BioLaser is running an end of the year special on their I+. And supposedly that if you mention my name, that you will get an extra discount on top. Is that right, David?
That's every day, Dr. Chang. That's every day.
Yeah.
Well,
and,
we actually.
Right. And just so the audience know that I am one of the BioLaser trainers on the advanced perio laser courses. You can specifically ask me to come to your office to provide that advanced perio training as part of the I+ package as well. So, I mean, that's, there's just a lot of stuff that we cannot cover all in a short period of time.
Yeah, and I think most of us understand the webinars are intended to drive general information exchange and create interest. So I think you did a great job of that. There is a question or two I'd love to get to in the 2 minutes we have left, if that's okay, Dr. Chang.
Sure.
And I like this one because it was about patient acceptance, and obviously I think having worked around periodontists for a long while, sometimes the patient reported outcomes and patient feedback can be less than optimal to some of these procedures. So the question is, how is the recovery when you do employ Waterlays, to get after some of these, clinical conditions? And is patient acceptance to that type of treatment a problem in your experience?
Yeah, so I use laser every day, pretty much on every single procedure I perform. There's doesn't matter if I'm performing a extraction bone graft, it doesn't matter if I'm performing a soft tissue graft, I'm using the laser because there's always things you can do with a laser that will help improve your success, your treatment outcome. And as far as with patients, when I mention, I say, hey, I'm using a laser, to detoxify the area, to clean the root, or to make the incision. They're always wowed by it, and maybe it's a just a patient knowing that they had the laser instead of the scalpel blade. They always come back and say, you know what, it didn't hurt that bad, or I didn't experience much pain. So I'm not really sure if just the patient placebo effect or if there's an actual benefit. But I do know one thing is, if you believe in laser, if you use it every day, you can see increased success outcome on all of your periodontal procedures.
Excellent. Thank you.